I'm Dr. Chris Johnson, and I'm a professor in the Department of Ophthalmology and Vision Sciences at the University of Iowa. And I mainly do development of diagnostic tests such as perimetry and contrast sensitivity and visual acuity. Pulsar uses a high rate of flicker, temporal frequency, and a low spatial frequency. So it's very broad rings and interleaves those with the flicker quite a bit. So you get kind of a concentric movement, centrifugal movement of an outward series of circles. And really the compelling issue is the motion that occurs with the pulsar perimeter stimulus. Top is tendency-oriented perimetry, and it's a spatial averaging type of procedure. It's one that is bracketing to get to the threshold, so it will present targets that are brighter than can be seen and are dimmer than can be seen, and it then brackets until the person is able to just barely detect the target. It uses neighboring points as well to determine this, and it's a very fast strategy, so it is much more efficient than some of the earlier strategies. Pulsar was evaluated with several other techniques, one which I helped develop called frequency doubling perimetry, also matrix perimetry, and standard perimetry. And we also had several structural tests as well as visual function tests. And we tested people that had healthy vision of all ages, people with elevated intraocular pressure but normal standard visual fields and normal optic disc and retinal nerve fiber layer, people with abnormalities of their structure in the retinal nerve fiber layer and the optic disc but a normal visual field, and people with glaucoma. And actually pulsar perimetry did a little bit better than all of the other techniques in terms of distinguishing among those different groups. So that was very promising in terms of our results. What are the differences between frequency doubling and standard automated perimetry? Well, standard automated perimetry is an increment threshold. You have a uniform background and you present a small increase in light at a localized region and look at how much light has to be added to that background to make it just detectable. So it's called an increment threshold. Frequency doubling uses contrast where it has light and dark bars that are present, and it measures how light and how dark those bars have to be to make it just detectable from a background. So it's a little bit different, and it seems to be an easier technique that many patients and many children have for being able to perform the test than standard perimetry. I think they prefer it. There are many, many cues compared to standard perimetry where it's just the light flashing on or off that is present. With the pulsar stimulus, one has motion, one has contrast, one has flicker, and many different components. So it's much easier for them to determine when they see a target and when they don't see a target. They feel more confident, and actually we are able to get results from some patients and some populations where it's difficult to use standard testing. I think that patients prefer the pulsar technique to standard perimetry because there are so many more aspects of the stimulus that they have to detect, such as motion, flicker, contrast, and other aspects rather than just a light turning on or off. We performed a multi-center evaluation with a clinical site in Italy, a clinical site in Argentina, and one in Portland, Oregon in the United States. And we looked at the learning effect and also the reliability. And for all of the different populations, the healthy controls, the elevated intraocular pressure, glaucomatous optic neuropathy, and primary open-angle glaucoma, it performed quite reliably and consistently, and there was a minimal learning effect. And I think this is very good as a clinical test procedure because it shows that it's quite robust and it can be generally used in many different environments. When we received the prototype of the Pulsar perimeter, I was concerned that at the calibration of it, was it actually able to adjust the levels consistently and have a good calibration of the stimuli? So we performed a very, very thorough assessment of it and found it to be quite reliable and quite consistent and accurate. In addition, we looked at how much the effects of blur would affect the results, differences in pupil size, and in the amount of lighting in the room. And we found that pupil size from 1 millimeter up to larger sizes did not really affect the results, that you could have blur up to 4 to 6 diopters, quite significant amount of blur, and it would not affect the test results, and that at least for daylight level conditions, normal lighting conditions indoors, there were no differences in that, so in the response. So I think that this is really a very good indication that it can be used in a variety of different clinical settings. I think that Pulsar perimetry can affect the workload in daily practice because it can provide information that would be very difficult to obtain in some populations. If someone has a neurologic disorder, something affecting the brain or the pathways to the brain, they can sometimes have problems with attention and with also maintaining good cognitive determination and such during the test procedure. Fatigue can also be an issue. And in children, they have a very short attention span. And this is enough like a video game that it keeps the attention intact and allows you to test more patients that might be difficult with other techniques, which can be boring or just distracting for them. Our experience to date with the Pulsar perimeter by Octopus in the Octopus 600 perimeter has been very favorable to date. And the fact that several centers in Italy, Argentina, and the United States have produced similar results, I think this is quite promising. However, I think the ultimate value of it in terms of clinical practice will be when many people are allowed to use it, because then we will find where the trouble spots are and where the advantages are. It is always most useful to see how it performs when it's outside the laboratory and clinic of the person that is doing most of the developmental work, and people who are not familiar with that are able to use it in a variety of settings. And that is something that we can look forward to for the future.